ahead and get started. So good afternoon. Happy Friday, everyone. I hope everyone's doing well today. Thank you so much for taking time out to join our echo session today. Before we get started, can I please have everyone set their Zoom name as their first and last name, as this helps me with identifying who is on.
I turned the volume.
Next slide, please.
Oops. Shit. Okay.
If this is not your first echo session with us, then this will look familiar. So, no, you're fine. If you could go back one slide. So this is not your first echo session with us, and this will look familiar. This is the structure of all of our echo sessions, starting with announcements, introductions, followed by a didactic session. So today's topic will be focusing on pharmacotherapy considerations in older adults with cognitive impairment, and then moving on into our collaborative case discussion, followed by closing and reminders. Next slide, please. So to make sure the sessions run smoothly, please remember to mute yourself when you're not speaking to prevent background noise. Introduce yourself with your name and location prior to speaking. Please maintain confidentiality when speaking about your clients by refraining from including any identifying information, and please respect others and their opinions. Next slide, please. So we are CME accredited. Our main objective is to empower providers to feel capable and comfortable with the assessment and care planning for dementia and to expand access to geriatric specialty care throughout California and beyond. So today's session is accredited for 1 CME credit, and certificates will be sent out by our CME office at the end of each month and will outline the total number of hours you attended. And many other licensing boards like the California Board of Nursing also recognizes CME for reciprocity. Next slide, please. So our series is a part of the HCBS Dementia Careware Award, which is supported by the California Department of Healthcare Services. One of the main goals for our grant is to create a dementia-friendly California for the population in need of equitable and excellent care for older adults, and train geriatric specialists, primary care providers, and health professional trainees, and help expand our geriatrics workforce. Next slide, please. So we would like to have everyone take the time to quickly introduce themselves on video. But since we have quite a few people on the line, which is wonderful, we will go ahead and have everyone introduce yourself via the chat function if you can. And when doing so, please list your name, role, site, and location. Next slide, please. So in the meantime, we will go ahead and have our hub team introduce themselves on video so you can get to know us. I'll get us started. My name is Manal Khan, and I'm the project manager for our Dementia Careware project at UCI Health, and we are located in Orange, California. So Dr. Gurvich, if you would like to go ahead.
I'm Gurvich. I'm a clinical pharmacist and professor of geriatric pharmacology at USC School of Pharmacy. And my practice site is at UCI Senior Health Center, where I see geriatric patients with all kinds of comorbidities and long med lists.
Thank you, Dr. Gurvich. Dr. Sehgal?
Welcome, everybody. I'm Sonia Sehgal. I'm a clinical professor in the Department of Internal Medicine and the Division of Geriatric Medicine and Gerontology, and I practice at the Senior Health Center in Orange, California at UC Irvine. Welcome.
Thank you, Dr. Sehgal. And Dr. Lee.
Hello, everyone. My name is Jeong-Ah, and I'm Associate Professor of School of Nursing and working with geriatric medicine on the dementia care awareness, and I'm supporting the family caregivers. Thank you.
Thank you, Dr. Lee. Next slide, please. So before we get started, we would like to give a little bit more background on Dr. Gurvich. So Dr. Sehgal, if you'd like to go ahead.
Yes, absolutely. It is my absolute pleasure to introduce Dr. Tatiana Gurvich. She is a clinical geriatric pharmacist. She has over 30 years of experience during the course of her career. She started out teaching family medicine residents, where she taught pharmacology to physicians in training. She's now an assistant professor at USC School of Pharmacy, where she teaches didactics and experiential courses. As she mentioned before, her clinical practice site is at the UCI Senior Health Center in Orange, California, and she provides care to a very complex panel of patients. She participates in 2 geriatric workforce enhancement program projects, one at USC and the other with us at UC Irvine. And she is instrumental in developing geriatric education curricula for primary care providers and other healthcare professionals. She co-chairs the Geriatric Pharmacy Care Council at CHSP, a group promoting geriatric pharmacy at the state level and to all California pharmacy schools. It's personally a pleasure to introduce her to you all. She is an incredible resource, and I'm really looking forward to her talk. So thank you, Dr. Gurvich, for being here today.
Thank you for having me. Okay, so we're going to talk about medications and cognitive impairment in older adults. So what I wanted to do today is talk a little bit about the polypharmacy issue that older adults often face because of their multiple comorbidities and multiple medications they use. Look at some medication-related problems that exist in cognitively impaired patients. Look at a little bit of the Beers criteria as it pertains to cognitive decline, and look at a patient case at the end, and also talk about medications that we use in cognitively impaired patients. So this is not a very uncommon picture that we see at the Senior Health Center. This is a patient bringing in all of their medications to a medication assessment program at UCI, literally bags of stuff. And I'm sure you realize that among these medications, there's lots of medications that can potentially contribute to cognitive impairment in these potentially demented patients. So going through these med lists is very important to rule out one of the reversible causes of cognitive decline, which is medications. This is what herbal usage sometimes looks like in an older adult. This is a patient's pantry that we found at a home visit at low-income housing. The patient was actually complaining of having no money for food. So we immediately went into his kitchen and looked in his pantry, and this is what we found. So in addition to all the potential duplication and general adverse events that this kind of a mess can create, if you look on the third shelf here, there are a bunch of tinctures. The second active ingredient in most tinctures is alcohol. So tinctures are typically 30, 40, 50% alcohol content. And if this patient were to take all of these tinctures on a daily basis, he could easily get the equivalent of 2 to 3 alcoholic beverages a day, which if he had any kind of cognitive impairment would be a problem. And if you look at his medication list on the other side of the slide, there are only 4 meds. So this is technically not even polypharmacy if you consider that it's only a number-driven definition. 5 or more medications puts you at risk for polypharmacy. This is only 4. But on this list, there's clonazepam, which is a longer acting benzodiazepine. And in combination with all the potential alcohol, that could completely contribute to memory loss, confusion, things like that. Also, you know, the alcohol, the clonazepam, the Flomax, and the Proscar can also cause dizziness and fall risk increase. So this patient, even on the short med list, could get into a lot of trouble with the medications. So when we think about geriatric syndromes like memory loss, confusion, depression, dizziness, drowsiness, you go around this wheel and see these common conditions that older adults have. You know, as a pharmacist, I see this wheel and I see medication side effects. I'm sure providers on this call see medical problems that they work up and treat, but from my perspective, these could all be medication side effects, easily reversible if you stop the offending agent. So a very smart physician, I think he practiced on the East Coast, Jerry Jurwitz, said, any symptom of an elderly patient should be considered a drug side effect until proven otherwise. So let's look at potential polypharmacy as it relates to cognitive decline. So technically, if you're looking at number-driven definitions of polypharmacy, it's usually 5 or more puts you at risk. So whenever you see a list of 5 medications the patient has, please review it to make sure that none of those medications are inappropriate and they're all being prescribed for the right reason at the right dose. When you see a medication that has no apparent indication, that's maybe the time to discontinue it to reduce pill burden and potential adverse events. You know, we see a lot of duplication in medications. This often happens completely inadvertently. You may have discontinued something at the previous visit. The patient didn't remember to discontinue or didn't understand to do so. And now they're on multiple muscle relaxants, multiple SSRIs, multiple medications for pain, which can contribute to cognitive impairment. CNS medications, their side effects are cumulative. So if your patients are taking cocktails of CNS active meds, that could potentially cause dizziness, confusion, sedation, grogginess, and so that needs to be dealt with if you're thinking the patient may be cognitively impaired. Reviewing the over-the-counter med list is very important. I think the statistics show that about a quarter of your patients will never tell you what they're taking over the counter. And there are a lot of things over the counter that are high risk. This is a picture of some of them. So all of these agents on top have a first-generation antihistamine, which is sedating and can cause all kinds of anticholinergic effects. But the most important one here is cognitive impairment and confusion. So we often see patients taking Tylenol PM for sleep and pain, Advil PM, same kind of idea. Last week in clinic, I saw somebody who was on Robitussin DM nighttime, which has doxylamine in it, which is an anticholinergic antihistamine, which could be contributing to that patient's cognitive impairment. So going over the OTC market meds is really important, and to actually have them bring them into the office so you can see what active ingredients they have. On the bottom of this picture, there are a bunch of herbal products and alternative medications that could potentially contribute to cognitive decline. One is belladonna, which is a naturally occurring herb that's anticholinergic. Valerian root is a relative of a benzodiazepine and potentially can cause the same issue as benzos. Cannabis, we're still really not sure what effect cannabis has on older adults' memory and whether it can make it worse. Most of the studies on cannabis do not use frail elderly in their studies. So we really have no idea. And obviously getting a good alcohol history on the patient is important to find out how often he drinks, how much, how big the glasses are that they use. So all that stuff is important. You also want to focus on high-risk medications as described in the Beers criteria, which we'll go over in a couple of slides. And really any medication that not necessarily listed on the Beers list, but any medication with a CNS component should be dosed very carefully and very judiciously in an older adult, selecting those agents that are better tolerated. Obviously, other medical problems need to be treated appropriately. And in terms of geriatric doses, the guideline for older adult dosing is to start with half the regular dose, do a slower titration than you would in a younger patient, but do get to a therapeutic level. So that's why we have the slogan, start low, go slow, but do go. Oops, I'm stuck. Okay. This is a table taken out of the newly updated Beers list, which was just updated in 2022. So this is the most up-to-date version of it. And this is sort of the bread and butter of the Beers list. This list has been there since its inception in 1988, I think. And it lists all medications with an anticholinergic profile. So some of these are pretty old and we don't see them much anymore. So for example, tricyclic antidepressants are all on this list. We typically don't use them much and shouldn't be using them in older adults, even at low doses. For example, amitriptyline is highly anticholinergic, and even at a dose of 10 milligrams at bedtime could potentially produce anticholinergic effects and therefore cognitive decline. But also things like paroxetine is on this list right here. That's an SSRI. It's got a little bit of anticholinergic activity, so probably not ideal in someone who's exhibiting issues with memory, and you may be concerned that they have some kind of cognitive impairment. Some of the antiemetics are here. Compazine we don't use very much anymore, but promethazine is Phenergan. We've been using it like water during the COVID epidemic for cough. And so just keep in mind that it is anticholinergic, not first choice for an older adult with cough. It can cause cognition issues. And it's also sometimes listed in the antihistamine section, which is the one right below it. So just stay away from it. In the antihistamine section, there are a bunch of over-the-counter meds, brompheniramine, chlorpheniramine, diphenhydramine, doxylamine. All of these are over-the-counter antihistamines that can produce cognitive impairment. Hydroxyzine is still prescription, so be careful prescribing that as well. On the top of the table, you've got all the urinary antispasmodics that are used for overactive bladder. They all have anticholinergic profile. Not equal. Oxybutynin is probably the worst one. Trospium is probably better tolerated, but I've seen confusion and cognitive decline even in patients on trospium. So getting rid of those medications it would be really helpful before you go ahead and diagnose someone with dementia. We now have a couple of different options for treating overactive bladder. So beta-3 agonists like Gemtesa or Myrbetriq are maybe better alternatives. So we've got options there. Some antipsychotics, most of them are old. We don't generally use them, but then there's olanzapine, which is an atypical antipsychotic, and it still has pretty significant anticholinergic effect. Some GI antispasmodics on the bottom used for irritable bowel with a predominant symptom of diarrhea should be avoided, and some muscle relaxants, particularly those with anticholinergic profile. The other thing that's important for this Beers iteration is that they really want you to understand that there's this concept of anticholinergic load, so that if one medication can cause some cognition problems and some adverse events, multiple medications in the same patient can contribute to more of that. So you really want to keep the anticholinergic load down in these patients. Another table taken out of the Beers criteria with a 2022 update. So I'm just focusing today on medications that can cause cognitive impairment. So sedation, cognitive impairment, falls and fracture risk. These are all medications that can contribute. So all muscle relaxants, not just the ones on the previous slide. Benzodiazepines, non-benzodiazepine hypnotics, so the Z drugs, Ambien, Lunesta, Sonata can all contribute to cognitive impairment. And antipsychotics, which we often use for agitation-related purposes. There's a 2022 update, which really makes a very strong statement about using them really as a last resort, because the risk of these medications is increased stroke risk and increased mortality, even at the lower doses that we're going to use for dementia. And I think there's a lecture later on where I actually review the entire Beers criteria. So this is just going to focus on cognitive impairment. So the benzodiazepines, this is the 2022 update. There's going to be really strong language in this iteration of the Beers list to really avoid benzos. They can cause abuse, misuse, there's addiction potential. Obviously, you don't want to use them in conjunction with opioids, but also older adults have increased sensitivity to benzodiazepines due to changes in metabolism, their ability to accumulate with multiple dosing. And so it really puts them at risk for cognitive impairment, delirium, falls, and motor vehicle accidents have been reported with benzo use. So you really have to be careful. With antipsychotics, we use them for agitation in our demented patients, but it's not an FDA-approved indication. So the Beers panel wants you to know that we are using it off-label, and you really should avoid use and only use it as a last resort. So first, when you're seeing patients with dementia with agitation, you want to intervene by using behavioral interventions, modifiable triggers should be eliminated, and all of that needs to be clearly documented. And if that doesn't work, then you go ahead and use the antipsychotics. If there are any pharmacists on the line who do long-term care, we're very familiar with this. We've been doing this for years. But the Beers criteria is now sort of making that a point to address. You do want to use the lowest effective dose. You do want to deprescribe periodically, and this decision to use the antipsychotics has to be done in collaboration with care partners, family members, caregivers, and patients if they're able to participate. More in the Beers criteria. So these are the drugs that you really want to avoid in delirium and cognitive impairment. So tricyclic antidepressants due to their anticholinergic effects, anticholinergics in general, all sedative hypnotics, some antipsychotics, particularly those with anticholinergic profile, steroids, and beta blockers in the presence of active delirium. They're making a distinction here because in active delirium, you should avoid H2 blockers, but for chronic use, they prefer to use H2 blockers over PPIs. And again, I'll address that issue with the next lecture, I think. Also, falls and syncope, cholinesterase inhibitors are on this list, and those are the medications we use for dementia. So you have to be very careful in titrating the doses up if there's a falls history in your patients. So medication cascade is a very common way to get into a polypharmacy mess. So what this is you're giving a medication that causes a side effect that you then treat with other medications that causes more side effects and more problems. So this is a very common example of how you can get into a cognitive impairment kind of a trouble. So amlodipine given for hypertension, it causes edema. One way to treat that edema is to give a diuretic like hydrochlorothiazide. In an older adult, that could result in frequency of urination and potential incontinence. Then you're going to go ahead and treat incontinence with an overactive bladder medication like oxybutynin, which would be the wrong choice. And that leads to confusion, memory impairment, and possibly a misdiagnosis of dementia. So you want to avoid that kind of a situation. So overall management of older adults with cognitive decline, you want to go over the med list, and this is what you want to rule out. You want to rule out reversible causes before you slap that diagnosis on, and medications are one of the reversible causes of cognitive impairment. You want to go over prescriptions, over-the-counter medications, herbal products, and cannabis. You want to screen for medication cascades and get rid of as many as you can. You also want to manage very carefully and hopefully effectively insomnia, depression, and anxiety, picking those medications very carefully. And I think we're going to do another lecture on these specific meds. Obviously, you want to make sure thyroid function is okay, and vitamin deficiencies like B12, which is associated with cognitive impairment. If you're concerned about vascular dementia, you want to make sure hypertension is well managed, and so is hyperlipidemia. You also want to add medications that you use to treat dementia, which we'll go over in the next slides. You want to monitor for progression and really monitor and manage behavioral problems as they come up. With as few medications as possible, with very careful choices, lower doses, and we'll go over some of that in the next couple of slides. You want to provide education to the patients, the family members, and the caregivers, and you really want to manage expectations in that, dementia is not going to go away, it's not going to get better, but with some of this treatment, what you may do is delay the progression of the disease and give the patient a little bit more functionality for a longer period of time. So these are the drugs that we would use for agitation. These are the antipsychotics that we're using off-label for agitation and those kinds of behaviors. So there's a black box warning on all of these drugs for increased risk of stroke and death when used in elderly demented patients. So you have to have that conversation with whoever is medically in charge of the patient. What you want to do is identify specific problem behaviors. So writing orders for PRN agitation is really not sufficient, because what agitation may mean to you versus the caregiver is something very different. So you want to identify specific behaviors. So pulling hair, striking out, biting, refusing care. These behaviors have to be a risk to the patient or a risk to the caregiver. Otherwise, we shouldn't be using these meds. We want to monitor for efficacy because they don't always work. We start them and the behavior continues or gets worse. We don't want to continue these meds. We want to use lower doses than we would typically use in younger patients. And these are kind of the doses we typically use in these patients. You want to avoid olanzapine because it's highly anticholinergic. We in our clinic, we usually use risperidone, quetiapine, a little bit of Abilify if it's covered by insurance. Pimavanserin is sort of the newest kid on the market in that sense, and it doesn't have the same side effect profile as the others, and it may be very effective. The problem I find is practical. It's never covered by Medicare Part D plan, so it's very difficult to get somebody on pimavanserin. And the doses, as you can see, are very low, sort of baby doses to manage these specific behaviors. So now we're going to talk about medications that stabilize cognitive decline. So you've got a couple of options. You've either got cholinesterase inhibitors that you can use, Aricept, Exelon, Razidine, or Namenda. And there's a combination product with Memantine and Donepezil. And really what you expect to see is a delay in progression of symptoms. If you start treatment early, you may get more benefit. If you start treatment late, you may get less benefit. And so as you can see, this little bump here, onset of efficacy in later treatment. And so all you can do is really delay the progression, not reverse any damage already done. So that's important to keep in mind. So this is a table of all the cholinesterase inhibitors that are available to you. They're, in terms of efficacy, they're fairly similar. We tend to use either donepezil or rivastigmine. We use donepezil because it's easy. Look, it's got a long half-life, 70 hours. It's a once-a-day drug. You start them on 5 milligrams. If they tolerate it in a month, you go to 10, and you're kind of done. There is this 23 milligram dosing strength pill, but it really doesn't add any more to the efficacy of the drug. I think it just adds more cholinergic side effects. Rivastigmine in oral form is really poorly tolerated and actually worse than donepezil, but in patch form, it's tolerated well. And so if swallowing is an issue and you'd like to use a patch, you can do that as well. So the way these drugs work is that they inhibit the breakdown of acetylcholine, increasing cholinergic transmission. So the kinds of side effects you're going to see from these medications are cholinergic in nature. So diarrhea, nausea, vomiting, anorexia, weight loss. Those are prominently featured with these meds. And I've listed some percentages here for you. So these are very high. In older adults, we see side effects that happen less than 2% of the time. So when nausea happens almost 20% of the time, that's a huge problem. It also causes bradycardia. So you really have to keep an eye on that pulse. It causes dizziness and syncope, and that's why cholinesterase inhibitors are on the Beers criteria as to use with caution. In terms of sleep, it can cause vivid dreams and also somnolence. It causes frequency urination and incontinence, and obviously that's a really big showstopper in terms of quality of life. So you really have to keep an eye on that. It also causes drooling, runny nose, and watery eyes. And when I talk to patients, I often, see something like a chlorpheniramine on the list, and ask, why are you?
Dr. Gurvich, I think you're muted.
When did I stop?
You were just talking about drooling, runny nose, and watery eyes.
Okay. So a lot of patients complain about those symptoms when they start cholinesterase inhibitors, and their way of dealing with it is going to the pharmacy and buying one of those first generation antihistamines, which are anticholinergic. So now you're giving a cholinergic drug for their dementia and an anticholinergic drug for their side effects. So that's complete contraindication. The other side effect sometimes these things have is headache. Oh my goodness, now it's stuck. Okay. So for cholinesterase inhibitors, you really want to talk about some practical issues with patients. The degree of benefit is small. So again, you have to set expectations. Don't expect a miracle. When we start somebody on donepezil or Exelon, we tell them, don't expect any change. If you see no change, that means the medication is working because it's delaying the progression of symptoms. The effects on cognition are very mild. You may see some improvement in independence and self-care, and it stabilizes or slows down the decline by about a year, roughly. You want to talk about gastrointestinal side effects, and you may have to reduce the dose if those appear. What you also want to pay attention to is decrease in appetite and weight loss later into therapy. We don't want our older adults to lose weight. And again, urinary frequency and incontinence could be a huge quality of life problem. So that's another reason not to increase the dose, or maybe go to something like memantine, which causes that less. You want to keep an eye on that heart rate, and especially when you're using these medications in combination with something that you would treat AFib with, like calcium channel blockers or beta blockers. That together they can often have additive effects on pulse. And the other thing you want to talk about with caregivers and families is, how long do we take this for? What happens if you stop the drug? We usually recommend you continue these medications as long as limited decline. As the decline becomes more progressive, then I think it becomes time to kind of consider backing off therapy and deprescribe. And by all means, if these patients are on these medications, do not use anticholinergic meds with them, because you're really counteracting the effect of these meds. Okay, the next drug we have is Memantine, or Namenda. This is a brand name. And this is an NMDA receptor antagonist, and it appears to be neuroprotective in nature. In dementia patients, you seem to have excessive NMDA receptor stimulation, which can cause neurotoxicity. So these drugs are neuroprotective in that sense. And they're also not particularly effective. They're usually used in moderate to severe Alzheimer's disease. And they are, what you typically see on standardized tests is a slight increase in the number. So a 1 to 2 point increase on a Mini-Mental status exam when these drugs are used. So little, and there's little evidence in its efficacy in mild disease. So you generally reserve it for more severe cases. Again, you're going to see a slower decline in overall function and slower loss of activities of daily living. And there's really not a huge effect on cognition. It can be used in vascular disease, again, with this slowness of progression. And sometimes these drugs are used in combination with cholinesterase inhibitors when the patients progress to more advanced disease. In terms of side effects, Memantine is much better tolerated than donepezil, I think. You do get some agitation in the beginning. So when you start this drug, you really want to monitor carefully, make sure the patient doesn't become agitated when you start this medication. A little diarrhea, insomnia, dizziness, headaches, and maybe hallucinations. So that's another thing to watch out, especially as you're titrating the drug up. In terms of dosage, it's generally a BID drug for immediate release. So you start with 5 milligrams and titrate to 10 twice a day, increasing by 5 milligrams every week. There's also an extended release formulation that you can use. I think it's generally more expensive. In terms of important pharmacokinetic issues, it does have to be renally adjusted in patients with reduced creatinine clearance. So creatinine clearance less than 30, you'd want to reduce the dose to 5 twice a day. So basic principles of Memantine use is treat upon using, reaching moderate to severe symptoms. Use it in conjunction with cholinesterase inhibitors, evaluate for adverse drug reactions in the beginning every 2 to 4 weeks, and evaluate for effectiveness about 3 to 6 months. So now I want to talk a little bit about the 2 new drugs that were pretty recently approved for Alzheimer's disease. This was a pretty big deal because there's nothing that's been approved since 2003. So I think in late 2021, aducanumab was approved. And then just a week ago, a second monoclonal antibody, lecanemab, was approved as well. So these drugs were both approved via the accelerated approval pathway. And when aducanumab was approved, there was a giant ruckus. So the FDA convened an advisory committee which rejected the approval of it, and the FDA approved it anyway. CMS then looked at the drug and decided that it was only going to cover it in clinical trials. So it's not really covered by insurance plans at this point. And there was a congressional investigation that resulted from this approval process. So for lecanemab, what they did is that they didn't convene an advisory committee. They just approved it via accelerated pathway without one. And so there's a little bit of controversy around that. So, but let's look at this, how these drugs work and how effective they are. So aducanumab, it's a monoclonal antibody which disrupts the production of amyloid beta plaques. It's an IV medication given every 4 weeks with a slow titration done every 8 weeks, starting with 1 milligram per kilogram, and the target dose is really 10 milligrams per kilogram. Not everybody can tolerate the 10 mg per kilogram dose. So sometimes doses have to be reduced. No drug-drug interactions in terms of the CYP450, so you don't have to worry about inhibition or induction of enzymes. And then no need to adjust renally or hepatically. The biggest issue with both of these drugs actually is the adverse events. So they both have amyloid-related imaging abnormalities, ARIA, edema, and hemorrhage. And with aducanumab, it's pretty high, 35% for edema, 21% for hemorrhage. Clinically, when you see this on imaging, patients present with headaches, confusion, delirium, mental status changes, dizziness, all kinds of side effects that are problematic. Again, these things that appear 2% of the time are going to appear more frequently in your frail or older adults. And other side effects are things like increased risk of falling and diarrhea. And these drugs are really used in early stages. So with MCI or mild dementia, the cost of these medicines is $56,000 a year. So this is a very expensive drug, and that was part of the uproar that it would really be limiting in terms of use in patients who can't afford this medication. In terms of clinical trials, there were a couple of four trials, really. One phase 1 trial of 165 patients and a couple of phase 3 trials with about 3,200 patients total. So in the first trial, the smaller trial, it was a 12-month treatment, and there were no amyloid beta plaques seen on PET scans after 12 months at the target dose of 10 milligrams per kilogram. So these drugs appeared to eliminate those plaques. 31% of patients who received the high dose had to discontinue due to adverse events. And these imaging abnormalities were more common with your ApoE4 carriers, these are patients who are genetically predisposed to having Alzheimer's disease. In the phase 3 trial, again, used in mild cognitive impairment or early dementia with an MMSE score greater than 24. And, for those patients who had this carrier, they were getting the lower dose of the drug, 6 milligrams per kilogram, not 10. And the length of the study was 78 weeks. And so the outcomes were, they looked at some cognitive screening tests to see how effective this drug was. And they were kind of mixed results. There was worsening in one trial compared to placebo, and in another trial they did show improvement compared to placebo, but clinical relevance was unclear because the actual improvement on cognitive tests was very mild, and 40% of those patients did not complete trial. So the data on this drug is not great. For the new drug, the newest one that literally just got approved last Friday, Leqembi, same mechanism of action as aducanumab, also an infusion drug, but the infusion schedule is a little bit different. The maximum dose is 10 milligrams per kilogram. There are no contraindication. There's going to be a different dosing for those with imaging abnormalities. It's going to be a lower dose. In terms of side effects, you get the same kind. You get the edema and you get the hemorrhages on MRI, but they're less frequent. So 10% for edema and 6% for hemorrhage. Clinically, you see headaches 14% of the time, and you see a lot of infusion-related reactions, which are not that atypical for infusion-related drugs. So that's sort of par for the course, I think. Other things you see are things like cough and diarrhea, and the cost is about half of what the original monoclonal antibody was, but it's still prohibitive for people on fixed budgets and low income. In terms of trials, there was one study that was really just a dose finding study. They did a bunch of dementia screening tools like clinical dementia rating, mini mental status exam, Alzheimer's disease assessment scale, cognitive subscale. And what they found was that this drug had a 64% likelihood of a 25% or greater slowing of the progression from primary endpoints compared to placebo. And this was not statistically significant, so not a great result. A couple of other trials for this drug. There's a Clarity trial that's still under the review by the FDA. placebo-controlled, double-blind, parallel group, randomized trial. And they looked, what it seemed to do is it reduced cognitive and functional decline by 27% at 18 months compared to placebo of using this medication. And after 18 months, there seemed to be continued slow disease progression, slow decline of activities of daily living, and slow decline of cognitive function. So overall positive results. Adverse events we already discussed on the previous slide. And the conclusion of this trial was that it resulted in less decline on measures of cognition and function, but was associated with significant adverse events. So what I'd like to do now is present a patient case. 81-year-old female brought in by her son for medication evaluation. Mom is taking too many pills. When I hear patients, family or caregivers say that to me, I kind of assume there's going to be a problem because patients or families and caregivers are pretty attuned to that. So I'm expecting a long med list. Past medical history, pretty typical: hypertension, diabetes, GERD, osteoporosis, osteoarthritis. What I'm concerned about here is frequent UTIs with urinary incontinence and a recent diagnosis of dementia. So I want to know what happened first, the chicken or the egg. If the dementia diagnosis was made first and then they developed UTIs and incontinence, that's one thing, but you want to make sure that the diagnosis wasn't made while they were having a UTI or after, being put on some overactive bladder medication, which can contribute to cognitive decline. Chief complaint: chronic agitation, frequent urination, loose stools, nausea, generalized muscle pain, which she attributes to old age. So as a pharmacist, when I look at this chief complaint, all I see is side effects. I'm sure some providers see some medical issues they need to work up and treat. But from my perspective, this could all be drug side effects. So you do want to look at the list to make sure that none of these things are reversible. In terms of vitals and labs, blood pressure is a little bit elevated. I've given you creatinine clearance here, estimated creatinine clearance 41.3, so she's a little bit renally impaired. Vitamin D level is a little bit low. A1C is a little bit probably overcorrected for her age. Lipid panel is fine. Metformin diarrhea is not really a side effect. It's an adverse reaction, so that's worth a discussion if we're going to change her diabetic treatment. So when I look, so this is her med list. Do you want me to ask for comments or do you want me to just go over it?
Whichever works for you better.
I'll just go over it. So today we're only talking about cognitive impairment, right? So let's focus on the drugs that can potentially contribute. So she's on amitriptyline 10 milligrams at HS. So again, it's a tricyclic antidepressant with a very high anticholinergic profile. And this is a low dose. So, but even at low dose, 10 milligrams of amitriptyline can contribute to some cognition related problems. So you shouldn't be diagnosing someone with dementia when you've got this drug on the list. In addition, you've got tramadol here, which is obviously a narcotic, and I really want to know how often she takes it. If she really takes it TID on a daily basis, then that may be a problem and could be contributing to fatigue and maybe some memory issues. Oxybutynin is another anticholinergic medication, not at a large dose, but together with amitriptyline, that's increasing anticholinergic load. So not an appropriate drug for someone with cognitive impairment. And again, promethazine for nausea, again, I want to know how often she takes it, but even if she takes it periodically in combination with oxybutynin and amitriptyline, that's a triple anticholinergic load. So you really want to avoid that and choose something for nausea that's maybe better, more appropriate. On this side of the slide, you've got a giant dose of aspirin, which is probably causing her to be on pantoprazole. So there's a little medication cascade going on. When you look at her diabetes regimen, I mean, this is kind of a strange way to deal with a demented woman's diabetes, but she's getting poked multiple times with insulin injections, both long-acting and short-acting, plus all the blood glucose testing. And if this woman is truly demented, how is she going to be able to coordinate all the injections? How is she going to know how much insulin to inject with every meal? So when you're dealing with a demented person or someone with cognitive impairment, you really want to make sure that the regimen you give them for all their diseases is manageable, and either the caregivers can manage it or the patient can manage it, him or herself. So this is really not appropriate for someone with dementia. There are other cascades here going on as well, but since we're just focusing on cognitive impairment, I won't go into that. And I think that's it. So there's lots of polypharmacy issues, high-risk medications are involved, potentially inappropriate medications based on guidelines and renal function, lots of medication cascades and pharmacodynamic interactions. So finally, so what you want to do is really review the med list, simplify it and consolidate medications when you can, eliminate any high-risk medications that can contribute to dementia, treat all the reversible medical conditions. In terms of dosing, you want to start low, go slow, but do go. You want to use the Beers list as a guide to avoid certain meds and use them with care. And you want to manage expectations of patients, families, and caregivers to not expect miracles, but just kind of stay steady. And you know, if you get a little bit of a delay in progression, that's a good thing. That's more quality of life for you and your loved ones. And I think that's it.
Thank you so much, Dr. Gurvich. Thank you. We do have some questions in the chat that I will read aloud. So first question, when an older adult sees multiple specialists, how can we advise her or him to discuss polypharmacy matters?
So this is actually a really common problem, polyprovider polypharmacy. I just wrote an article about it. It was published in the American Society of Consultant Pharmacists. I think this is where family primary care physicians are key. You know, I think it's really hard to talk to specialists about polypharmacy because they're only managing their own disease state. They will most likely refer that patient to the primary care office. So that's where you come in. I think primary care physicians have to be in touch with all specialists and coordinate care. And if you see a problem with a medication list that somebody else prescribed, reach out to that specialist. They may not be realizing that there are other things on the list that could be causing an adverse drug reaction or an adverse event. So I think this is where primary care, this is why it's so vital that the patient has a good primary care doctor who can deal with the polypharmacy concern. I mean, you know, if you have access to clinical pharmacists who see medication lists from all providers, I think that's also useful. Refer to them for med review and take their recommendations.
Thank you. A few questions here. How much or how anticholinergic is ondansetron?
I don't think it's, well, its primary mechanism of action is not through anticholinergic effect. So I don't think I think that's the one that I would use if somebody's having nausea as opposed to compazine.
Does losartan contribute to cognitive impairment?
Not as far as I know, but you know, when you're looking at blood pressure management, if you're over treating and the patient becomes hypotensive, for example, that could potentially create a situation of fatigue, maybe a little bit of a memory problem. Just, you know, you do need blood flow going to the brain to function. So but I don't think losartan directly causes cognitive decline, except when it's being used to lower blood pressure too much.
Thank you. Do you have favorites or recommendations for persistent severe insomnia in which patients are requesting meds and state no benefit with melatonin?
So that's a very common question. So when they say melatonin doesn't work, I want to know how much did they try and for how long. So sometimes there are different formulations of melatonin. You want to make sure they're Their pharmacy carries the melatonin that was at least screened for purity standardization. So, and the doses of melatonin are wide. It's anywhere from efficacies from anywhere from 1 to 3 milligrams all the way up to 10 to sometimes 15. So I want to know what dose of melatonin they tried and didn't work for them. I like Rosarum, which is a melatonin agonist. If melatonin was partially effective, I would try Rosarum because that's a pharmaceutical grade melatonin agonist. I would really be stubborn and not prescribe the Z drugs because especially in those cognitively impaired patients, I would not prescribe benzodiazepines. I think trazodone has a role. Again, it's a dosing range anywhere from 25 to somewhere around 100. So working with that drug and increasing it gradually can be effective. If they're also depressed and are losing weight, you might try mirtazapine at a lower dose, 7.5 milligrams. And in our really frail patients, we sometimes use 3.75. So the lower dose of mirtazapine is more sedating. It's harder to do sleep hygiene in patients who are demented, but if you have a non-demented patient, I would really recommend doing a visit, just discussing sleep hygiene, because that's probably the most effective thing you can do. I saw something in the chat about doxepin. So if you noticed on the anticholinergic list, the first table I showed, doxepin was a problem at greater than 6 milligrams. That's because there is a low dose doxepin available under brand name that escapes me at the moment. But at that dose, it's supposed to cause fewer anticholinergic effects. Now, in our clinic, I would be very hard pressed to get any of our providers to prescribe it in patients that we know have a cognitive problem. So we don't use it in those patients. But if they don't have a cognition problem, you might be able to use very low dose doxepin. So 6 milligrams would probably be okay.
Thank you, Dr. Gurbich. Any other questions for her?
I do have a question. This is Miriam Rahimi, UCI. Thank you for the presentation. The patient you had in this case, she came in with amitriptyline, gabapentin, and tramadol. How would you approach weaning these medication off without the patients complaining of increased pain or insomnia?
So in that patient, so the amitriptyline 10 milligrams has to go. That's not a negotiation. It's low dose. You can just stop it. You don't have to titrate it off. So if she was getting the amitriptyline for neuropathic pain, if you looked at her creatinine clearance, it was pretty good. It was in the 40s. So she could actually tolerate a higher dose of gabapentin if that was the issue. So you could do, I think she was on 300, I believe. So you could do, you could increase it to maybe 600 at bedtime. It would also help her sleep. So if amitriptyline was given for that, that could help with that as well. So you could work with a gabapentin. The tramadol, you really want to back off. So my first question would be, how often do you take it? If she takes it once a month, it's not an issue. But if she takes it multiple times a day, you kind of want to figure out another pain management approach. I noticed that she was not taking any Tylenol, for example. That would be an option. You'd also want to know where the pain is coming from. Sometimes these topical agents like Voltaren gel can be effective. Lidocaine patches can work. Voltaren gel comes with this little measuring stick that's usually stuck to the top or the bottom of the packaging. Most patients don't realize it's there. And it actually asks you to measure out the dose. So if they measure out the 2 grams or the 4 grams, it actually does work reasonably well in certain parts of the body. So I would explore all those options with the patient. And the other option, I mean, if it's a chronic pain thing, you could consider duloxetine instead of amitriptyline, starting with a low dose and titrating up. So there are lots of options here.
Okay. And can I ask a question regarding the medication she was using for frequent urination for overactive bladder? How would you approach that in this patient who does have an overactive bladder?
So the funny thing is that these overactive bladder medications are not that effective. If you look at clinical trials and some trials comparing the drug to behavioral interventions, the behavioral interventions are often more effective than the drugs. So getting, a diary to keep track of all the incontinence episode may be helpful in that way. We've got two options in beta-3 agonists now, which is Myrbetriq, which can sometimes raise blood pressure. So with her blood pressure being in the 150s, maybe I don't want to go there. Although her losartan dose was low, we could go up. We could increase that a little bit. But Myrbetriq can cause, an increase in blood pressure. But Gemtesa, which was approved recently, and I think is being covered more by Medicare Part D plans, and you can certainly do a PA for it. That's also used for an overactive bladder. Same mechanism. It doesn't affect acetylcholine, but it does. It's a beta-3 agonist. It can help with that. So if you need to use a drug, that's what I would use. But I would, when somebody comes in with incontinence, I would first screen for drugs that can increase frequency first and see if I can get rid of them. Sometimes people drink a lot of coffee, water, wine, so you got to manage that. And if that doesn't work, then you go to the drugs.
Thank you. This was very useful.
Welcome.
Thank you, Dr. Gurvich. One last question from the chat. Wanting confirmation that loratadine, fexofenadine, Zyrtec for allergies are appropriate.
Those are better options. Yes, they should not be. They should not have any anticholinergic effects. Sometimes Zyrtec, cetirizine can make you tired. So I would use it at night, but the others should be okay. You also want to stay away from anything with D on it. So no Claritin D, no Zyrtec D, because D is a decongestant, pseudoephedrine, which can cause a lot of agitation in your demented patients. So hypertension, anxiety, insomnia, and agitation. So you want to stay away from that.
Thank you so very much.
Perfect. Thank you so much, Dr. Gurvich, for speaking today. You had a wonderful presentation. So just before everyone goes, if you wish to receive CMEs, please fill out the form at the following link, or you can scan the QR codes. We also ask that you complete the evaluation form, as this helps with our continuous quality improvement efforts. So this presentation and links will be sent in a follow-up email before the end of the day, and I will also be sending out a link to last week's recording. So please join us next Friday, January 20th, for our office hours, in which you may bring any and all questions related to dementia. And I will be sending out a Zoom invite at the beginning of next week with more information. So thank you again, everyone, and thank you, Dr. Gurvich, and we hope to see you all at our office hours next Friday. Thank you.
Thank you. Bye.
Thank you.
Was that okay?
That was great.
Was it okay? Really? Okay. All right. Thanks. Okay. I'll see you guys later.
Okay.
Okay. Bye.